Dr. Shannon Acker, who's an assistant professor in the pediatric surgery division. The talk this morning will revolve around pediatric shock index and applying it to injured pediatric patients. Shannon is a longtime Colorado resident and I believe a native of Colorado. She did her undergraduate training at Boston University Medical School at Case Western, and then did a lot of training here at the University of Colorado. General surgery, a pediatric surgery fellowship, and she's in her second year on faculty. I was just reviewing her CV over the weekend, and she almost has 50 peer-reviewed publications. And remember, in her second year of faculty. She's off to a great start in academic surgery and really has all the makings of an academic leader. And Shannon, we really look forward to your talk. Thank you.
Thank you, Dr. Schulich. So I'm going to be talking about a lot of work that I did actually while I was in the lab doing research as a resident. So I'm going to talk about the shock index pediatric age adjusted. So my objectives are to summarize how the shock index pediatric age adjusted, or SIPA, varies from traditional vital signs in the evaluation of the injured child. Also to identify children in whom SIPA may be helpful in the clinical evaluation, and describe how SIPA is used to help differentiate mild from severe injury in children. So to start with a little bit of background, a lot of this talk is about trauma triage. So trauma triage refers to how trauma centers use the information that the EMS providers call into the emergency department to help determine which patients need to go to a trauma center and when we need to call the trauma team down to the ED to be there to evaluate the patient when they arrive. And so the risk of under triage is that you'll have patients with missed injuries, and the risk of over triage is that it leads to overcrowding of trauma centers with mildly injured patients. And so while every trauma center has their own trauma triage activation criteria, there are published tools, obviously, to help with this. One of the more common ones is the revised trauma score. So the revised trauma score incorporates the patient's respiratory rate, the systolic blood pressure, and the GCS to help guide trauma centers as to when they need to activate the trauma team. And so this revised trauma score is very helpful in the adult population, but it's very limited in children because it's really difficult for the EMS providers to accurately measure a child's GCS. And also the normal vital signs vary by patient age. And so to assist in trauma triage, in the adult literature, groups have started to use something called the shock index. The shock index is equal to the heart rate divided by the systolic blood pressure. So in a normal resting adult with a heart rate of 80 and a systolic blood pressure of 120, a normal shock index is around 0.67. But in a patient who's just had a trauma and is in hemorrhagic shock, they become tachycardic and hypotensive, which leads to elevation of their shock index. And so in the adult trauma literature, a shock index of greater than or equal to 0.9 prior to hospital arrival is predictive of mortality in the trauma population, as well as need for massive transfusion. And so some work that we did back about 5 years ago was to try and determine if we could use age-adjusted vital signs to improve the performance of the shock index in the pediatric trauma population. So we defined the shock index pediatric age adjusted. And to do this, we looked at just published normal vital signs by patient age. And we took the maximum normal heart rate divided by the minimum normal systolic blood pressure to define the maximum normal shock index for a kid. So for children age 4 to 6 years old, the maximum normal shock index is actually 1.2. So in an adult, it's much, much lower than in kids. And then by the time you get to be 12 years old, the adult base cutoffs apply. And so in our initial publication where we defined this, we looked at all children age 4 to 16 who were admitted to one of our 2 trauma centers following a blunt traumatic injury over a 7-year period. We only included pretty severely injured children who had an injury severity score of greater than or equal to 15. And we evaluated the ability of both an elevated shock index based on adult cutoffs as well as the elevated age-adjusted cutoffs shock index to predict a variety of outcomes. And so looking at this population of injured children, we found that nearly half of them presented with an elevated shock index based on the adult values, but only 28% had an elevated age-adjusted shock index. And we found that an elevation in either of these was associated with a variety of adverse outcomes, as had been shown in the adult population. We found that elevated SIPA or shock index was associated with a higher injury severity score, higher need for blood transfusion, longer hospital and ICU length of stay, longer need for ventilation, higher rate of severe injury, a higher risk of blood transfusion among patients with a blunt liver or spleen injury, and a higher risk of in-hospital mortality. But what we also did was compared the ability of the adult cutoffs compared to our pediatric age-adjusted cutoffs to predict these outcomes. And so that's what the graph on the right is. The black bars are the adult-based cutoffs, and the gray are the pediatric-based cutoffs. And we found that for each of these adverse outcomes, the pediatric-based age cutoffs better identified these, or better predicted these adverse outcomes for children. And so based on these data, we concluded that the age-adjusted shock index, or SIPA, was better able to identify severely injured children than unadjusted shock index. And so other groups have both validated and expanded these findings. This work came out of Ohio State. This group queried the 2014 pediatric TQIP database. They expanded our work by establishing a cutoff for ages 1 to 3 and showed basically using the same protocol that we did, and showed that a shock index of greater than 1.2 would be abnormal in this age group. They also included patients who had suffered penetrating trauma, and they also included any patient who was admitted to the trauma center, not just those with an injury severity score of greater than 15. And in this TQIP population, they confirmed our previous findings. They found that both elevated shock index using adult cutoffs and SIPA were associated with greater injury severity score and worse overall outcomes. However, the associations were stronger for SIPA. And then they did a subset analysis among the group of patients with an ISS of greater than 15 and showed that the associations were even stronger in this group of severely injured children. The other conclusion from this manuscript that was really important was they started to look at the utility of a normal shock index or a normal SIPA at the time of presentation. And they found that kids who presented with a normal SIPA, this reliably excluded severe injury, need for ICU admission, or increased mortality risk. And then one of the other early studies that sort of, this is the graph from their TQIP publication. So the hatch, it's similar to the graph I showed from our initial publication. The hatch bars refer to the whole patient population. The solid bars are just the subset with an injury severity score of greater than or equal to 15. And similar to our publication, they showed that the age-adjusted cutoffs better predicted these adverse outcomes for kids than the adult-based cutoffs. And this was one other publication that was very similar to these initial two, looking specifically at the population of patients with blunt liver or spleen injury. And so this comes from the Atomic Consortium. It's a consortium of 10 level 1 pediatric trauma centers. And they performed a similar evaluation looking at all children with blunt liver or spleen injury admitted to one of their 10 trauma centers. And they compared the ability of elevated shock index to elevated SIPA to predict adverse outcomes. And again, with SIPA in the black bars and adult-based shock index cutoffs in the hatched bars, they showed that SIPA was better able to predict adverse outcomes in the pediatric trauma population. The other important finding from this work was that they showed that SIPA was very sensitive in the setting of blunt liver and spleen injury. So 95% of children who required a blood transfusion within the first 24 hours after injury presented with an elevated SIPA. And similarly, 98% of children who required an operation for their liver or spleen injury presented with an elevated SIPA. So this is really helpful in identifying the most severely injured children. So just to summarize this initial work, we've shown that elevated SIPA at the time of presentation to the ED is associated with severe injury, need for blood product transfusion, need for ICU admission, ventilator use, and overall mortality. And SIPA performs better than an unadjusted shock index, and the findings are similar among the subset of patients with blunt liver or spleen injury. And so the next question that we asked was, how can we use a normal SIPA? If an elevated SIPA helps us identify severely injured children, what does a normal SIPA tell us about pediatric trauma patients? And so just a little bit of background, in adult trauma, a CAT scan is a very useful tool. It very quickly helps you identify and diagnose traumatic injuries. But something that we think a lot about in kids, but not so much in adults, is the risk of the radiation associated with the CAT scan. So the risk of carcinogenesis related to the radiation from a CAT scan is much, much higher in children. And that's because their tissues are still growing. And they also have more years ahead of them to develop a future cancer. So if you look at the pediatric literature, the risk of a future solid cancer related to an abdominal CT scan is higher the younger the child is. The risk is also higher in girls than it is in boys because they have more tissue in their abdomen that's susceptible to radiation-induced injury. And so what this paper showed us was that if you took 300 5-year-old girls and obtained an abdominal CAT scan, one of those 300 would develop a new solid cancer related to the radiation alone. And so we're often thinking about how do we limit the number of CAT scans that we get in the pediatric trauma population. And so this is a publication from a few years ago. We wanted to figure out, is there a population of children where it's safe to forego an abdominal CAT scan after blunt abdominal trauma? And so this was a population, we looked only at patients who had a diagnosed blunt liver or spleen injury. So this includes kids with just a grade 1 injury that are managed non-operatively and require no interventions. We defined a low risk group and an at-risk group. And so among this population of kids with blunt liver or spleen injury, we defined the low risk group as those who had an injury owing to a single non-motorized force. So this excluded anybody in an MVC or an ATV accident. Kids must have a GCS that was normal on presentation to the ED, and then also a normal SIPA on ED presentation. And we found that the kids who met this criteria, of those children who were admitted to the hospital, there was only one in that cohort who even required a blood transfusion, and otherwise none of them required any interventions, and all were discharged home in stable condition. And so this is just something to consider. If you have a child who's got a blunt abdominal injury, if they have a normal GCS, a normal SIPA, and it's not an MVC or an ATV accident, it might be safe to not get an abdominal CAT scan and save them the risk of the radiation. Similarly, the group in Boston asked, how do we use a normal SIPA to help us with management of these children? So again, looking at the population of children with blunt liver and spleen injuries, they asked the question, can we safely decrease the number of kids that need to be admitted to the ICU based on a normal SIPA presentation? And they really wanted to get at, should hemodynamic status guide management instead of the injury grade? And so to understand this, the way that we manage blunt liver and spleen injuries in the pediatric population is based on the guidelines from the American Pediatric Surgical Association. And these really are dictated based on the grade of the injury on the final radiology report. And so the APSA guidelines say that a child with a grade 4 injury should be admitted to the ICU. And so that's how we have historically been managing these children. And so the group in Boston asked if that was really necessary. And so they performed a single center retrospective review. They looked at about 15 years worth of data, looked at 133 children who met criteria for ICU admission based on having the presence of a grade 4 higher liver, spleen, or renal injury. And they wanted to figure out how many of these 133 children actually required an ICU level intervention. So they defined ICU level interventions as need for blood transfusion, need for an operation, vasopressor support, or need for advanced airway management. And among these 133 children, only 14% of them required one of those interventions. And when they looked more closely at this group who required ICU level interventions, they found that 18 of the 19 had either an elevated SIPA or hematocrit less than 30% on presentation. And so using these two criteria, they found that they had a sensitivity of 95% and negative predictive value of 99% for identifying which children required admission to the ICU following their injury. So that's sort of the data on how we use normal SIPA. I wanted to talk a little bit about how we can use SIPA in trauma team activation. So like I mentioned at the beginning, the goal of trauma team activation criteria is to use the information that EMS calls into the emergency provider to determine which children are going to require an emergent intervention upon arrival to the hospital. And so in the pediatric literature, there are consensus criteria that define who needs trauma team activation. And so we're trying to use the pre-hospital information to identify the kids who are going to need these interventions. So the interventions include advanced airway management, chest tube placement, ED thoracotomy, essentially any operation, any interventional radiology, vasopressors, a burr hole or ICP monitor. They want to identify kids with spinal cord injuries or unstable spinal fractures, and any child who arrives in cardiac arrest. And so we wanted to, us and a couple other groups wanted to determine if an elevated SIPA could help us identify children who met these consensus criteria. So we performed a review of blunt injured children who are admitted to either Children's Hospital or Denver Health. And we found that elevated SIPA was better able to identify kids who met these consensus criteria than age-adjusted hypotension. The group out of Phoenix performed a similar review. They evaluated 1 year of trauma admissions at their center and found that, as had been shown previously, elevated SIPA was better than the age or the adult-based shock index cutoffs at identifying kids who met these consensus criteria, and that using SIPA as opposed to the adult cutoff was less likely to lead to over triage. They also showed that EMS or pre-hospital SIPA and ED SIPA performed similarly, which is sort of an important point if we're trying to use the EMS information to help us with trauma triage. But what's most important from these data is that it's a really low positive predictive value and sensitivity for elevated SIPA. So the positive predictive value is less than 12%. So while an elevated SIPA prior to hospital arrival will identify the most severely injured children, it's going to lead to significant over triage. And so the conclusion from these data are that it really shouldn't be used as an activation criteria alone due to this over triage. And we actually found that at Children's as well. During 2019, we added elevated SIPA to our trauma team activation criteria. And during the course, it was about a 9-month period where we used it as an activation criteria. There were 12 children who had an elevated SIPA prior to hospital arrival, 5 of whom were activated at the highest level, 5 of whom were activated at our sort of second level of trauma activation. And then 2 of them were trauma consults. But of these 12 patients, only 2 of them actually met the consensus criteria. So we ended up taking SIPA out of our activation criteria because our data again show that it shouldn't be used alone as trauma activation criteria. So to summarize these data, again, we've shown that SIPA is better than age-adjusted hypotension or shock index using adult cutoffs at identifying severely injured children. However, it has poor sensitivity and positive predictive value when used as an isolated indicator. And so the next couple of questions are still where we need to go next and what work still needs to be done. And so since we know that SIPA can't be used in isolation, we asked the question, can we combine SIPA with other factors to improve its performance? And then finally, we wanted to look a little bit at how we can follow SIPA over time to identify severe injury. And so this work actually came out of the University of Buffalo, I believe. And so going back to that first slide, talking about the criteria that trauma centers use to activate the trauma team, one of the more common scores is the revised trauma score. And so this group created a revised trauma score. And instead of using GCS, systolic blood pressure and respiratory rate, they used GCS, substituted SIPA for systolic blood pressure, substituted peripheral O2 saturation for respiratory rate, and then added the patient's temperature. They performed a retrospective review of about 5 years worth of data from the NTDB in both adults and children. And they found that this 4-factor revised RTS better predicted mortality in both adults and children than the original RTS. So this is some of the early work on how we combine SIPA with other factors to help make it a more useful score. In addition to trauma triage, we've looked at how we can use SIPA for massive transfusion protocol activation. So similar to trauma activation criteria, every trauma center has their own criteria about when they activate the massive transfusion protocol. One of the more commonly used scores based in the adult literature is this assessment of blood consumption or ABC score. The ABC score has 4 components, including penetrating mechanism, a systolic less than 90, heart rate greater than 120, and a positive fast. And the initial publication, they showed that a score of 2 or more warrants MTB activation and is 75% sensitive and 86% specific. And so this is from the adult population. And so a few years ago, we asked the question, how does the ABC score perform in the pediatric population? And can we make it better by adding SIPA to the ABC score? We looked at 50 children who received a packed red cell transfusion during their admission for blunt trauma. There were 31 in this group who received a transfusion within 6 hours of injury. Obviously, or as expected, the injury severity score was higher in this early transfusion group. But what is important about this and why the ABC score doesn't work well in children is that only 7 of the 50 had a positive FAST, and there were only 3 children with penetrating trauma. And so, FAST in children is a whole nother discussion, but FAST is very sensitive and specific in the adult trauma population. However, in kids, it's very specific, but not very sensitive. It's very unusual to have a child with a positive FAST, so it's just not as useful of a tool. And then thankfully, we don't have as high of rates of gunshot wounds and stab wounds in the pediatric population. And so we showed that, in the adult population, the sensitivity and specificity of the ABC score is greater than 75%. But in the pediatric population, because of the low rates of FAST and penetrating trauma, it's really not sensitive. Sensitivity was only 29% at predicting need for massive transfusion. We then looked at just elevated SIPA alone at predicting need for massive transfusion, and it performed better than the ABC score, but still not great. And then finally, we replaced systolic blood pressure and heart rate with elevated SIPA and showed that we could modestly improve the sensitivity of the ABC score in the pediatric population, but it still was not a great tool. And so based on these data, we concluded that adult-based criteria for MTP activation performed poorly in children, and the addition of SIPA modestly improves the sensitivity of the ABC score. And so to follow up this work, one of our recent lab residents, Dr. Phillips, tried to expand on this even further to figure out what score we can use to help us guide MTP activation in children. So he looked at about 11 years worth of data from our trauma registry, looked at all children who received a packed red cell transfusion. He included 211 children, 66 of whom met criteria for MTP, which in the pediatric population is defined as children who receive greater than 40 per kilo of packed red cells in the first 24 hours after their injury. And he compared different scoring tools to figure out which one performed the best. He looked at the ABC score as we had done previously. He looked at the ABC score, and SIPA is what the ABCS is. And then finally, he created the ABCD score, where he included penetrating mechanism, positive fast, elevated SIPA, and then added in elevated lactate and elevated base deficit. And he showed that adding in these two lab values improved the sensitivity to make the ABCD score comparable in terms of sensitivity and specificity to when it's applied to the adult populations. So I think this is sort of where we need to go next with SIPA, is combining it with other factors to make it a more useful tool to predict trauma activation criteria and MTP activation criteria. And then sort of the last thing I wanted to talk about is how do we use changing SIPA? Obviously, this is based on vital signs. We follow vital signs over time. And when we first created this, we imagined that it would be something that you would follow over time to help you identify which children were improving and which were getting worse. And so this work came from the University of Indiana. They looked at data from their single level 1 pediatric trauma center, included children with blunt injury and injury severity score greater than or equal to 15. And they found that among this group of blunt injured children, the kids who presented with a normal SIPA that became elevated within the first 24 hours after injury had increased rates of mortality, increased hospital length of stay, and increased ICU length of stay. Additionally, they looked at patients who had an elevated SIPA at the time of presentation and looked at how long it took with the resuscitation to normalize their SIPA. And they found that the time it took to normalize the SIPA correlated directly with hospital length of stay, ICU length of stay, total time on the ventilator, need for blood transfusion, and discharge to an inpatient rehabilitation facility. So I think this is some of the early work looking at how we can follow SIPA over time to help us guide resuscitation and management of pediatric trauma patients. A couple other papers looking at how SIPA changes from pre-hospital to ED presentation. This again comes out of Ohio State. They were looking at take-up data, looking at blunt trauma patients. And they found, again, that the elevated SIPA at the scene was a better predictor of adverse outcomes than the adult-based shock index cutoffs. And then they showed that a SIPA that remained elevated from the scene to the emergency department was associated with greater ISS, length of stay, ICU admission, higher rates of mechanical ventilator need, and overall higher mortality. And Dr. Phillips did a similar study here looking specifically at the population of patients with blunt solid organ injury and showed that patients who had an elevated SIPA prior to hospital arrival that remained elevated upon presentation to the emergency department were the population of patients who were most likely to require a blood transfusion for their blunt liver or spleen injury. So just a little bit of data on future directions of where we need to go to figure out how we can follow this over time to identify severely injured children. So to conclude, we've demonstrated that elevated SIPA identifies severely injured children. A normal SIPA helps us identify children at low risk of severe injury. We've also shown that elevated SIPA alone is a poor predictor of need for trauma team activation. And then elevated SIPA as part of a scoring system may improve pediatric trauma team and MTP activation criteria. And then finally, changing SIPA may help us identify more severely injured children. So I'm happy to take any questions if anyone has any.
Shannon, great talk. And we have a couple of minutes, so I want to encourage the audience to type in a comment or a question, but I can go ahead and start off. So when you pick these variables for the SIPA or the modifications for the SIPA, do you do this by what you think might add to it and then kind of test it out, or do you go through this in a mathematical way? And the reason I'm asking, I'll have a follow-up comment to that.
Yeah, I mean, I wish I could say that we had some sort of machine learning or large data set to help us identify which factors are really going to help with this, but it's mostly just based on trial and error and hypothesis and discussion amongst our group to see, you know, what do we think is going to be helpful here.
Yeah, that's what I thought you were going to say, and I have some great news for you and the rest of the department. So I've actually had a big hand in recruiting a Casey Green from the University of Pennsylvania. And he's going to start here on this campus in about a month or so. And he will be forming a new department within the School of Medicine, a department of bioinformatics and data sciences. And he's got a very large package from the dean and from other sources. And I bet you if you took this information to him, he could devise with you a plan to do this mathematically and, you know, take the variables in the current SIPA, maybe bump one or two of them out and add another two to come up with a much more sensitive and specific way to do it. So I highly encourage you to look him up when he arrives. I mean, this is right up his alley, and you know, he'll be a great resource to you. Yeah, and the other thing is, I noticed in, you know, some people have taken your SIPA and added things like the ABCD, but the problem with the ABCD is it requires laboratory values to be, and so, you know, you can't get that in the ambulance coming in, and it takes an hour realistically to get that information back. And by that time, you know, the pediatric trauma patients very often kind of sort themselves out. So yeah, it's more sensitive and specific, but it makes it much more time consuming and complicated.
Yeah, and that's why we've tried to use labs that are available on the point of care in the emergency, or that will come up with your initial blood gas. But you're exactly right. You know, most of these scores that are established in the adult literature are based on purely the information provided from the scene by the EMS providers. And so you're right, it's really difficult to figure out how we can adjust these for kids.
Yeah. And finally, my last question or comment is, it seems that the SIPA is a great tool for excluding kids who need a lot of resources in CAT scan. So, I mean, your data were pretty convincing and pretty strong. And you know, I didn't realize 1 in 300 kids who got a CAT scan got a cancer. That's a big deal. And I mean, just that in itself, I think, is a huge way to use the SIPA score.
Yeah, I agree. And I think we can do more work there as well. It's just a couple publications looking at normal SIPA. But I agree that, you know, this is very useful to help identify severely injured children. But as I've shown, there are a lot of limitations. But I think focusing more on how we use the normal score to exclude severe injury is useful. Yeah.
All right. Well, Dr. Acker, Shannon, great talk this morning. And, you know, for somebody so, you know, junior in their career, you have a body of work that spans, what, 5 or 6 years. And you're a great example of how to keep pursuing something and adding to it over time. So great work. And I look forward to hearing more about this over the coming years.
Thank you all for your help. I appreciate it.
All right. Thank you.